Okay, great. Welcome everyone. Thank you so much for joining us today. So welcome to the Statistical Methods for Health Equity webinar series. And this is our monthly webinar series focused on statistical and machine learning methods that have the potential to promote health equity. For example, methods that can shed light on complex factors underlying inequalities, or fairer algorithms that appropriately take into account the biases that exist in biomedical datasets. And so this is a series that's co-hosted by the Alan Turing Institute, specifically the Health Equity Interest Group, the UCL Statistical Science Department, and the Data Science for Health Equity Group. So that's also called DISHI. And DISHI is a global community of experts and enthusiasts working at the intersection of data science and health inequalities. And our aim is to ensure that the latest research and innovations in data science, machine learning, and AI improves everyone's health, and especially those in underserved populations. If this sounds like something you're interested in, there are a few ways to get involved, and I'll post in the chat some links if you're interested. And today it is my great pleasure to welcome John Ford, who is an academic public health doctor and a doctor of the Health Equity Evidence Centre. And I'm going to hand you over to John, who will introduce his talk and himself. But thanks so much, John.
Almost done my talking bit there. So great, thank you very much, Lizzie. So really pleased to be with you all. I followed this issue for a while now, so it's really nice to come meet you all. So as Lizzie says, I'm an academic public health doctor. So that means I'm clinically trained, worked in hospitals for a few years, and then took a sidestep into public health and public health research. I predominantly lead a program of research around health inequalities. I also work 1 day a week for NHS England, National Public Health Team, and I lead our Health Equity Evidence Centre. And today I'm really going to be talking about our Health Equity Evidence Centre work. The Health Equity Evidence Centre we set up about 16 months ago or so, with the main focus of trying to generate evidence around what works to address health and care inequalities. A big part of what we do is create evidence maps, living evidence maps, using machine learning. I'll tell you a little bit about that. First, a bit of a caveat. So I'm an applied public health and equity researcher. I'm not a statistician or a computer scientist. So I'll try and explain as much as I can, but I may have to point you to other resources if you've got questions about some of the technical side of stuff. Before we begin, I kind of want to just share what I mean by living evidence maps. So during this talk, I'll talk a bit about living evidence maps and how we generate them, but I'd like to just start by sharing that. So hopefully, if I do that, you can see our website. So this is our website, which we launched 16 months ago or so. And within our website, we've got living evidence maps. There's a series of them published, and anyone around the world can click on them and see the living evidence maps. This is what I mean by living evidence map. So essentially, for this evidence map, we've got different disadvantaged groups, different primary care interventions. Each bubble relates to either a primary study, an umbrella review, or a systematic review.
This is a service and the next stop is control.
So there's a bit of background. Thanks. So each of the circles represents the number of studies, and you can click. So if you're interested in socioeconomic status and funding interventions, you can click on the 13 reviews, and it will drop down and give you 13 reviews. So it means that at our fingertips, we've got a body of evidence around what works to address inequalities. At the minute, to be included in our maps, it needs to fulfill 3 criteria. It needs to describe what works, some kind of intervention program or activity. It needs to focus on inequalities, so some domain of disadvantage. And thirdly, our initial funding came from primary care, so it needs to include some kind of primary care funding. So when I talk about living evidence maps, now you hopefully have a sense of what I'm talking about. So this project really arose when we got some initial seed funding from NHS England, East of England Primary Care Team. And they asked us to do 3 main things. One is they wanted to know what the evidence was around what works to address primary care inequalities. They wanted a bit of data on where to look and where to focus their efforts, which I'm not going to talk about today, but I can answer that in the discussion later if interested. And thirdly, they wanted us to create some online hub or resource centre, which is the Health Equity Evidence Centre website, which I've just shown you. So that's where it arose from. And over the next 20 minutes, 25 minutes, I'll talk about three main things. First of all, why we need to embrace machine learning to help with this process of navigating the literature. Secondly, I'll talk a little bit about the machine learning software that we use and how we've used it to create these living evidence maps. I'll give you a bit more of a demonstration at the end, depending on time. So for those of you who've done systematic reviews, hopefully this process is fairly familiar with you. So it starts off with, designing a research question and then searching some databases, identifying a list, screening some titles, abstracts, extracting data, synthesizing it, writing something up, and hopefully at some point sharing it. I started my research career with NICE, so the National Institute for Health and Care Excellence. And we would quite often do these reviews for new drugs which were coming to the market for the NHS to use. The problem with this process is it takes a long time. So some previous researchers have estimated it takes about 16 months on average from designing that research question to finally getting something published and in the public domain, which means for policymakers, practitioners who want quick answers on what they should be doing, actually 16 months is too long for them. Not only does it take a long time, but it also takes a lot of researcher time, so it's quite labour intensive. So just want to give you an example. So this is a systematic review looking at dementia and chronic cognitive impairment for traumatic brain injury. And in this review, the authors did a search and found 77 or 78,000 records, and they manually screened each one of them. So looked through the title, plus or minus abstract of all 78,000. They found 300 which were relevant, but only 100 of those met the methodological standard. And of those 100, there was 8 which looked at either dementia, cognitive, or chronic cognitive impairment. So it meant that the researchers spent a huge amount of time and effort to end up with their 8 studies. And while the reviews that we tend to do don't tend to get up to 78,000, the reviews that I tend to do historically have got maybe 5,000 to 10,000 articles. So it takes a long time for someone to sit through all those titles and abstracts. So not only do they take a long time, not only do they take a lot of research effort, but they also go out of date fairly quickly. So again, this is some research which looked at the time between the search strategy about when they looked for studies to when actually they published results, started sharing them. And they found it could be anything between 8 and 22 months. So that means even the day the systematic review gets published, it can already be anything between 8 and 22 months out of date on average. And certainly that's my experience of having published a number of reviews, is actually by the time it finally gets published, there's quite often other research which has been published in the meantime. And even then within a year or two of publication, it suddenly starts looking outdated. We've also got an increasing number of research articles being published. So this is just data looking at primary care inequalities research articles. And, considering, the past 10 years, there's just been a huge increase in the number of research articles being published. And this is across the board. This isn't just in primary care inequalities, but there's just an increasing number of journal articles being published and lots of new journals springing up all the time. And so it's becoming increasingly unmanageable to keep on top of everything that's been published. So for all these reasons, our current approach to reviewing evidence is unsustainable because we're getting so much being published. We're also finding it easier to search and find. So certainly because the number of studies are being published is increasing, we're finding it easier to design search strategies to find papers which maybe previously we wouldn't have found. The questions which we were also asking are slightly different. So again, when I started my research career, maybe 15, 17 years ago, then actually the questions we had tend to be a bit more straightforward around either drugs, or if there's complex interventions, they'd be more straightforward. Whereas now we tend to be asked to do more complicated reviews. Undoubtedly, we've got there's always a pressure on resources in terms of making the most out of what we have. So that's where machine learning has really come to the fore. And certainly, having done lots of reviews in the past and published lots of reviews, it really feels like machine learning is the way forward and the way in which we'll be navigating the literature in the future. There's lots of ways in which machine learning could help us. So there's both in terms of identifying relevant research articles. So that could be both in the searching stage, but also the screening stage. So when we're looking for new articles, but also when we're having to screen through thousands of articles. There's also opportunities for it to help with data extraction, with the actual synthesis and writing of briefs. It can also help with kind of mapping research activity and identifying evidence gaps in research questions. Today, I'm mainly going to focus on identification of relevant articles, but happy to talk about some other opportunities as well. I think it's fair to say, actually, the past maybe 2-3 years, there's just been an explosion of the number of software packages that can help with each of these stages, especially with the advent of large language models, kind of transformer-based technology. What we've done is we've used software called EPPI Reviewer, which was developed by the EPPI Centre at UCL. And the way we've developed these living evidence maps is, first of all, we set up with a group of training materials that was based on our previous systematic reviews. So they were all our previous systematic reviews, particularly Statistical Equalities, which I'll tell you a bit about, focused on what works to address inequalities of primary care. We then used that to train a machine learning algorithm, and we then used that algorithm on a data set called OpenAlex, which has, it's now more like 250 million records. OpenAlex is similar to something like Google Scholar. We then added kind of belt and braces using citation tracking and something called related articles, which I'll tell you a bit about. And that process essentially ranked this database. So 1 being the most similar to our training material and 250 million have been the least similar. And we essentially looked at the top of the pile and applied labels to them. And as we applied labels to them, they appeared in our living evidence map. Because this is a relatively efficient process, we can then do it every month. It takes about 1 or 2 days. And that process then keeps the evidence maps up to date. We can then recalibrate the algorithm and the classifier every so often to make sure that the algorithm is performing optimally. And based on the living evidence maps, then we produce evidence briefs, and I'll show you some of those in a moment. So our training material was something called Equalized Study, which we use kind of traditional academic systematic review methods for, and we just published. And essentially within this review, we did a search of some traditional electronic databases, so Medline, Embase. If you look at the left-hand side of this flow diagram, you'll see we started off with about 8,000 articles. we ended up including 251 of those 8,000, and those were 251 reviews, and we unzipped them to have another 6,500, and from those 6,500 we eventually ended up with 325. So hopefully you can now see that actually we'll have, based on this review, a set of studies which met our inclusion criteria, which we liked, set of exclusions studies which didn't meet the inclusion criteria and were excluded, and we can use that then to train a machine learning algorithm. We used an approach called the bag of words to vectorize the titles and abstracts. The bag of words approach, if you're not familiar with it, is essentially about applying or vectorizing the words in the title and abstract. So, for example, in this example, we're trying to identify randomized control trials. If you can imagine the article rows going from 1 to, could be 10,000, it could be many more, and the columns being different words in the title and abstract, and essentially they're applying a 1 if that word appears, and in the column at the very end, whether it's included or not, whether it's relevant. And so you can see the first article is relevant and includes the words randomized and range. The second article is relevant, includes random and randomized, but the third article is not relevant. It includes runnicity and systematic. You can then fairly easily calculate coefficients and either use traditional regression techniques or more neural network approaches to then create the algorithm using this approach. So essentially that's what we did. So we trained material, vectorized use this bag of words approach, create the coefficients from the training set, and then we can apply those coefficients in the training set onto OpenAlex with 250 million articles. That allows for priority screening. So that means we rank the studies from 1 to 250 million, and which means that we can then hopefully just be looking at the cream of the crop. So this is essentially what we're doing. So if you think about a traditional literature review, traditional screening, you would have just a random assortment of the right articles being included articles, a random distribution of included articles throughout screening, and essentially what we're doing is we're trying to pull the best ones to the top. In reality, it looks much more like this, where it keeps going on and on and on, and we can pull the best ones to the top. Another way of describing this is essentially we're trying to identify the most relevant studies at the earliest point. So the grey line here being a completely random distribution of included studies, the red line being where there's poor performance, and essentially we're aiming to train the algorithm so we can identify the studies which are most similar to our training set as early on as possible. So in addition to the priority screening using the training set, we also do citation tracking. So this has been done for years, both backwards and forwards. So that means that if a study cites another article, or if a future study cites that article, then there's some citation mapping that we include to identify other relevant articles. And there's also something called consequent relationships. So if you look at, for example, PubMed or many of the main, the big journal publishers, they have kind of recommended reading, which goes alongside any article. And that uses some citation tracking and some machine learning to identify similar articles. And so we also include those. So clearly studies which have a high prioritization plus have some citation relationship and related articles get higher priority. So that means essentially we still have to manually look through the top of the pile, but it's much more efficient, and it means that we can then keep on top of what we're doing. What we then do as a research team is we then use those evidence maps to create short evidence summaries, all focused on what works. We tend to take the topics from ICBs, so integrated care boards, or NHS, mainly NHS England. And they tend to ask us fairly complicated questions. So things like, how do we address inequalities in referrals from GPs to hospitals? And so it means that using our evidence maps, we can turn around these evidence summaries in about 4 to 6 weeks. So traditionally, it might have taken us maybe 3 to 4 months. But we can turn in a much shorter period. We then use something called grade to communicate the certainty of recommendations. It's grade's a way of assessing the certainty of recommendations. And the idea of the evidence centre is to use transferable evidence. So this idea that certainly when a lot of reviews I've done in the past, you start off the review process and you may be able to find 3 or 4 studies, and you end up with a review which says, there's not very much research published, but more research is needed. But actually, there's usually a whole body of research which can be logically applied to build the case. And so, for example, taking a group like Somali populations and thinking about what works to improve diabetes care for Somali populations. While there might not be much research published in that population group and condition, actually there'll be research published in other sub-Saharan African populations and or from other minoritized groups, which could be logically applied. What we're not trying to do a series of systematic views, so we kind of acknowledge that there may be studies which are missed, but the principle is that we have enough evidence to inform decision making. And we've now got a pipeline to academic publication where we're going to publish our evidence briefs as a mini series. We've done a whole range of topics. So these are just some of the examples, but they include some very clinical subjects like cervical screening or cholesterol management, to more kind of organizational topics like telephone triage, self-referral interface, all the way to kind of more health system topics like primary care funding, financial incentives, and anchor institutions. So a whole range of topics. So I just want to give you a quick overview of kind of live demonstration. So I've shown you our website. So these are living evidence maps. So these are the ones which are produced. Essentially, we can cut the data in lots of different ways. So it means that we've got 11 evidence maps up here, but they can be used in lots of different ways. Not only do the evidence maps show us where the evidence is, it also shows us where evidence isn't. So, for example, we look at let me just inclusion health groups. So, for example, this shows us that actually, for example, for Gypsy Roma traveller communities, there's very little published on what works. Whereas for other groups, there's much more published. And then what we do is then we then produce a range of these evidence briefs. So at the minute, I think we've got about 22, but they cover all different topics. So, for example, we've just done one on musculoskeletal conditions, and essentially evidence review then goes through a summary of the review, a bit of background, and then gives a summary of the evidence. And then we summarize the recommendations in using this kind of grade certainty, depending on how confident are we of that recommendation based on evidence. And then that gets shared with NHS colleagues, with us, NHS England, ICBs. So far, we've had really positive feedback, both in terms of the evidence maps and the evidence briefs. I guess from our perspective, we kind of think this is the future of how we navigate evidence. Undoubtedly, there's more that could be done here, both in terms of automating the data extraction and the synthesis. We use a bit for data extraction, not very much. We've certainly tried doing evidence synthesis using large language models, Claude, ChatGPT, but to date we haven't thought they've been as robust or reliable to use in our evidence briefs. Okay, I'll stop there and hand back to Lizzie.
Thank you very much, John. Thank you. That was such an interesting overview. I'll open the floor up for any questions, but I also have a question to start with. I was wondering, you were kind of talking about, I mean, there's normally always a lot of papers when you start searching in the subject, but the kind of requests you were getting were quite specific and could be quite niche sometimes. Is there ever a situation where you don't actually have enough papers, or the papers that are being pulled to the top actually differ quite substantially from the request that you're asking, because there just isn't, like, there's kind of there's lacking similarity to what you provided it with, as an example?
Yeah, and it's one of the really interesting things that we've learned is actually the questions which are asked by policymakers and practitioners are often quite different to what the questions that academics and researchers are asking. So, for example, we've been asked to look at things like how to address inequalities in self-referrals. So, for example, for physiotherapy services in particular, people can refer themselves to a physiotherapist, but we know that they tend to be taken up by white middle-class people. And so, how do you address inequalities in self-referrals? And actually, there's essentially we didn't find any research studies which looked at what to do about that. So there's plenty of research studies which describe the problem, not much which look at what to do about it. But this is where the idea of transferable evidence comes in. Actually, we know that there's some guiding principles around how to address inequalities. So we know that, for example, if we design high agency or high effort interventions, they tend to increase inequalities. So if we design services with lots of hoops to jump through, tend to increase inequalities. So actually, we can apply some of that transferable evidence into the areas of self-referral. So if we design self-referral programs, lots of hoops to jump through, where you have to register online and enter lots of details in and navigate lots of literature, is likely to increase inequalities. So the idea is that we use some of that transferable evidence, and then we use grade to communicate. So, like, clearly, the certainty of that evidence is not as great if it's been logically applied from a different area. So we then use grade to try and communicate how confident we are about the evidence underpinning some of the recommendations. But hopefully that means that we don't end up with these kind of empty reviews where we don't find any studies and we have to go back and say, sorry, there's no research, because that doesn't feel right, because there is clearly some evidence, even if it's not directly related to that specific topic.
Yeah, and I think it's really interesting. So I don't know, I'm a PhD student in academia, and I feel like there's so much research out there that never gets used. But it's kind of, this is a very exciting way that actually potentially a lot of different evidence can draw together to be used for something beneficial. Brio, please ask for questions.
Thank you. Hi, John. Thanks for the really, really interesting talk. I was curious. We've got a couple of questions, but I'll just start with the one. I was curious about your experience with LLMs and how you've found it so far. Like, what have you found it in terms of it being less robust compared to some of the approaches that you've presented today?
Yeah, good question. So alongside this, we're doing a grant with the Health Foundation looking at use of machine learning or AI across the evidence synthesis pathway. And I guess our experience has been that when we've used, particularly ChatGPT, we played around with a little bit of Claude, that there's been quite a lot of hallucination, especially around research studies. Like, we've been amazed at how inaccurate some of the studies have been, or some of the outputs have been, and how variable it is depending on the prompts used. Now, that was with ChatGPT 4.0. Like, certainly my experience with ChatGPT 4.5 has been much better. Yeah, and I suspect that, certainly, you know, my personal reflection about this is, I suspect within our research group we'll probably get to a point where we need to do some prompt engineering training to get everyone on board with how to use it, and to do some quality assurance, develop some quality assurance processes where we can be reassured. Like, it's the citations as well. Like, the citations have just been awful. Like, the citations have just it's just amazing, actually, how inaccurate some of the citations have come out. So we haven't embraced it yet. Like, I suspect it is coming. Like, our other slight reluctance is we're not quite sure if policymakers and practitioners will trust it. If they know that that most of the synthesis has come from a LLM, even with some quality assurance and quality checks from researchers. Yeah. One of our other reflections is, like, they tend to be pretty good at summarizing. They're not particularly good at synthesizing. So, you know, they tend to be pretty good at providing summaries of the studies, but we haven't quite got the level of synthesis where we're, you know, it's identifying themes and patterns and coming up with that in a consistent way. Don't know. I'm interested to hear other people's. I suspect everyone else is going through the same process of trying to work out what LLMs are good for and what they're not so good for.
I found similarly in terms of your summary there, in terms of synthesis versus summarization. I think summarization is pretty good at, but synthesis, it doesn't seem to be able to always pick out the kind of the common threads, like running through things. Just quickly, I'm going to jump in before Des, because you touched on something about trust, and I was wondering if you have received any pushback in terms of these machine learning approaches that any of the practitioners skeptical or anything like that compared to what you were doing before.
So in my experience with policymakers, practitioners, they love the machine learning to navigate the literature, create living evidence maps. They really like it. They particularly like as a practical, real example. I think there's quite a lot of sense in the policy circles I interact with, is that there's a lot of hype, over promise, under delivery of machine learning AI. I think it's slightly naive understanding that you could just chuck a whole load of data into a machine learning algorithm and spit out, tell you exactly what you should do. So people like it because it's tangible and see it. We've resisted using it for writing syntheses because there's we're not convinced that policymakers and practitioners would trust it, whether trust or have confidence in it. Again, we're doing a workshop, which maybe a plug. We're doing a workshop with Health Foundation in June, and we're essentially trying to explore this, bring together policymakers, practitioners, software engineers, and computer scientists. So we've got lots of policymakers and practitioners, and a few academics. But if anyone here is doing stuff in this area and wants to come and join us, please do let us know, because we're trying to explore that idea of, you know, do policymakers and practitioners trust summaries of literature based on machine learning and AI. And one other comment I would make is, I think we've also found it, you know, again, with things like data extraction and synthesis, much better it's with kind of quantitative numerical type data, whereas types of questions we're getting asked around, one of the questions was around how do you reduce inequalities in the interface between primary and secondary care, so referrals from GPs to hospitals. There's not much published, but they're kind of messy, complicated organizational questions, and again, the LMs just don't really seem to perform a lot well in terms of trying to synthesize the patterns in those types of studies. Again, good at summarizing. They're quite good at having a dialogue with, in terms of getting up to speed with some of the issues, but not really in terms of producing the synthesized output. So my experience.
Thank you.
Thank you very much. We're going to come to Debs, and then there's a couple of requests for things from you, John, if you're happy to like post some links in the chat. But Debs, go for it.
Hi, yeah, I'm probably the least knowledgeable on here, so I just want this question will probably expose my ignorance here. So I'm from Public Health Scotland, and we do systematic reviews, but all manually. So I'm just trying to. The first question is how long does it take? I'm looking at the slide that was like steps 1 to 6, and how long does that sort of process of training the algorithm, sort of 1, 2, 3, 4, how long does that take? And then the next question is, which is probably the really ignorant one, do you do that once? I mean, you do that once, and then that algorithm works for all different types of questions, like review questions?
So that's a really, really good and important question. So, like it took us probably about a year to develop it, although we're on a learning curve. So I suspect it could be done much quicker than that. But it took us a while to set up. And one of my main reflections is actually creating these living evidence maps makes a lot of sense if you've got a big topic where which is broad and quite vague. So like how to address inequalities in primary care, it works for. If I was doing a review of, chemotherapy drugs for breast cancer, it's probably not worth doing it in that, using the usual kind of PubMed Medline searches. You can fairly easily identify those studies. But actually, spending the time building infrastructure for complex policy questions, I think is worth time. Then means that I actually clearly once we've built the living evidence maps, we can then, we've got about 800 studies in there. We can turn into lots of different research questions, as long as it's within the primary care inequality space. So actually that's why we can now turn stuff around fairly quickly. Like we still do some great literature searching and we still do a quick PubMed and Google Scholar type search just to make sure we're not missing anything obvious. But actually, it means we've got it all at our fingertips, which makes it much more quick and efficient. So it means we do it once for that topic. It means if you come and ask me and say, actually, you're interested in inequalities in maternity services, we don't have anything in there for maternity services, because, if it's not within the primary care space. So it means then we'd have to do the whole process again for maternity services. So, for example, we've just been asked to do something similar for return to work. And we're going to have to go through probably a similar process, set up living evidence map for return to work. Actually,
Okay, that makes sense.
We've now got the skills and experience to do it relatively quickly.
Yeah, that makes sense. I've got you now. Okay, lovely. Thank you very much.
Thank you very much. We've got Justine. Feel free to unmute. Perfect.
Yes, sorry. My name is Justine. I do most of my research in sub-Saharan Africa, and you mentioned some challenges. But I don't know. I just missed exactly what you said. But how have you overcome some of those challenges? If you could even repeat them, then that would be lovely for me. Yeah.
So part of the challenge is get a good training set. Like clearly, if your training set's not very good, then it means that the classifier or the algorithm isn't very good. And certainly that was our experience. Actually, our initial output from the algorithm wasn't great, so we spent quite a lot of time refining the algorithm or the classifier. Which took time. So that's been one challenge. We then went through quite a robust quality assurance process, which meant a lot of manual checking versus what was coming out. And so that's why the whole process took about a year, just to get something which we were confident enough to share with others. I think there's also something around, like we had to come up with a categorization, how and again in retrospect we probably would have had slightly different categories to label. Yeah, so there's some of the main challenges. Like at the minute we don't include grey literature, which is a big gap, and actually ways of trying to include some grey literature, whether it's from Dimensions or Overton or some other data set, which includes some policy documents, would be really interesting.
Great. Thank you so much. There's a couple of requests for literature in the chat, just if you have anything on the methodology, but feel free to also email that to me and I can put it in our Slack group. And I have also provided a link to the website to access the evidence maps, as some people had asked about them. Yes, I am probably going to... Oh, Brio's got another question.
Sorry.
I'll let Brio dive in there, and then we were going to wrap up early, just because we need to finish a little bit early today.
Oh, sorry. We could. I don't need. It's not very urgent.
I think John's got like a few minutes, so he can maybe give a very rapid answer.
It would be great to the event that you mentioned in June. It would be great to get a link to that as well. And I think I possibly zoned out for a minute when in your talk. But I was curious about the grade system in the evidence briefs. Is that like a published methodology? If so, that would be great to get a link to that as well.
Yeah, I can send Lizzie some links. Yeah, so grades. It's usually used just for recommendations. So it's not a quality assessment tool for studies. It's really to communicate how confident we are of the evidence behind the recommendation. So if we're recommending, I don't know, a certain intervention, it's how much evidence is behind that recommendation. So we find it quite useful to use because it means that it means the policymakers can see how much evidence there is. And the risk is the policymakers, or what we say is low evidence. Policymakers may think, oh, that means there's, it's not good enough. When actually we're not saying it's not good enough. We're just saying that there's not that much research done on that topic. If that makes sense.
Yeah, got it. Thank you.
I will follow up with John for some links. It would also be really interesting to hear more about the Health Foundation event. You might find some useful people in the Dishy network as well to kind of invite to that. But thank you so much for your talk. It was really interesting. We're going to post a recording of it online. But yes, thank you very much. Thanks everyone for joining, and we'll see you in June for our next webinar.
Great, thanks.
Cheers, John. Bye-bye.
Bye.